Welcome back. I am Dr. Sanjay Chaudhary, and the following video is an educational video showing all the steps of a toric IOL surgery. The surgery was done as a live event at one of the biggest live surgery platform in India.
So welcome back to the OT1, and I'm going to show you surgery with Vivity Toric IOL, the Alcon extended depth of focus IOL. So I'll just show you the case. So if you look at this record, we check or do the case on two systems, the Varion system and the Interion system, that is by Heidelberg. And if two systems give us the same readings or similar readings, we say those readings are dependable. So if you look at this top picture, this picture shows and gives an instruction to the optom that when you place your head onto the diagnostic system like the Varion, the instrument is moved from one eye to the other eye and back, and it should be absolutely in the center of both the pupils. So that way you would know your head is absolutely straight. This is the most critical part of doing a toric IOL, that the head position has to be straight so that you get your axis accurate and the two machines can replicate or give a similar reading. So if you look at what the Varion gave, Varion gives us an axis of 175 and 85, and the Interion also gives us an axis of 175 and 85. So both the axes are exactly identical. However, the readings are slightly different. So let us take the Interion reading for comfort. So the anterior reading of the Interion, that means the K1, K2 is 40.99 and 42.61. That means the astigmatism is 1.62 and it is steeper at 85. So we have a vertically steep or with the rule axis of 1.62. Now this is the interesting line. Now when you look at the total K, that means the combination of the anterior and posterior K, the total K is 1.46, 0.2 less. So we all know and we understand that with the rule the astigmatism has to be reduced by 0.25, and against the rule the astigmatism has to be increased by 0.25.
In the previous case,
Against the rule it was, and his K was increased by 0.31. In this case it is with the rule and the K is getting reduced by 0.2. So previously it was assumed in Barrett's formula that in the vertical steep you reduce and in the horizontal steep you increase, but now with these newer devices like the Interion, we know exactly what is the total K, and then we base our calculations on the total K.
Okay,
there
right.
is no area of speculation.
Yes, Sanjay, I think we can start the case now,
Okay,
please.
so the usual steps we mark. Start kar de. Increase illumination. Okay, light पे देखिएगा. Start. Registration done. Next. And the axis is 87.
So you are going to mark it manually also?
Yeah, that'll give you an idea all through the surgery. So I'll remove the Varion, so we'll know where we are. थोड़ा सा लाइट के सेंटर में देखिएगा, जो दो लाइटें दिख रही हैं आपको. हाँ, ठीक है, आप हटा दे Varion. So the usual two ports.
Okay, sir. Sanjay, you are going to implant a Vivity Toric intraocular lens in this.
Yeah.
What about, again, I'm asking the same question, dysphotopsias or higher order abrasions, you think, how does it help?
Yeah, actually, Vivity IOLs are really not giving us any halo glares and loss of contrast. And he is able to see 6/6. It is meant for distance and intermediate, equivalent to an add of 1.25 or 1.5. So when we tell to the patient that we are going to do this lens, we say distance, intermediate and some near. So this is a very good way of saying and some near, because if you say near and the patient cannot read, the patient is uncomfortable. But if you say some near, that you could get something to read also, about 30% are able to read, but maybe another few are not able to read, but overall you will be able to see everything in a close by position. You will be able to do your routine activities without glasses, maybe see the mobile, a little enlarged font comfortably. And then the patient expectations, if pre-surgery are brought to the level that you want, this patient is comfortable with the outcome. So what we do say is that if the patient is very fussy, type A personality, I want this, I want that, then it is better to do Vivity. And if the patient is not too fussy, is a category where you could think of doing a panoptic. So both the lenses now have their role to play, and from what I see in most of the practices, both lenses are working well. You really have to decide what is the surgeon's mindset, because the patient is reading the surgeon and the surgeon has to be comfortable in what he is doing. For example, I am more comfortable in doing Vivities because I just want a post-op period where the patient is not using up too much of my chair time.
So Vivity also you can possibly implant in eyes which have some kind of a pathology like diabetics or aberrated eyes, which panoptics will not be that forgiving.
Yeah. So they have their own set of indications. Okay. So I do a direct chop center.
So I think again, how do you feel ever since you've acquired Active Sentry? How does it help you? Or you are such an accomplished surgeon, does it really make a difference?
No, it does. Active Sentry really does make a difference.
The pressures are very high, but 50.
So the Active Sentry really does make a difference. If you look at my Phaco settings on the screen, it is just 2.75 CD value. Now, when I didn't have the Active Sentry, this Phaco would have taken me to about 10 or plus. But see the way my Phaco energy use has dropped once I started using the Active Sentry and the Centurion system. So cutting power of the balance tip is what is making the difference, and the Active Sentry is what is giving me a dead stable chamber, and I am working with an IOP of 50, but even if you bring it down to 30 or 20, the chamber is still dead stable. So that's a personal choice that I prefer to stick on to 50. So I want a little more firmer chamber all the time. And the Active Sentry, what it has done is, from the previous version, they brought the sensor. The previous version, the sensor was in the console, the basic machine. Now from that console, they brought the sensor in the handpiece of the surgeon. So now that lag time by which the sensor used to detect changes in the interior chamber, has been reduced drastically, and that is why it can respond immediately to slight changes of intraocular pressure. Then the active fluidic system, that means the two plates which press the bag and control the fluid coming into the eye, gets activated and your chamber stays stable. It also has another very unique feature, and that feature is that it does active compensation for fluid leakage. which means whatever you may do, there would always be some fluid leakage, and then active sentry can sense it and immediately send the signal for more pressing of the plates and more fluidics into the eye to compensate for a fluid loss.
What polisher did you use just now?
Okay, this is just a clear polisher which is sandblasted
Also has irrigation coming
and
with
has
it.
irrigation coming out. So if you see with this irrigation coming out, the posterior capsule is not concave forward and almost flat. The AC is formed, and then I can see each and every fiber on the posterior capsule. Now imagine there was a time when we could never see the posterior capsule, and now we are seeing each and every fiber even in live surgery.
Okay, so this is the Vivity Toric intraocular lens
Yeah,
which you are implanting.
yeah. So let me just show you something. No, I'll show you once it is in the eye.
No, yeah, it will be seen better when it is in the eye.
Yeah.
So this is a yellow lens, so it has a UV blocking properties. It is on the platform of the Acrosoft IQ lens, which used to come earlier, which comes now also.
Okay, now there's a lot of discussion on whether a toric ICL should be implanted under visco or under hydro. So the concept is that if you implant it under visco, then the visco fills up the furnaces of the bag, and that is where the haptic is, and the haptic can move because of the lubrication properties in the bag in the early post-op period. So if you do it under hydro, then there is minimal visco in the chamber, almost nil in the bag, and the chances of early lens rotation is again minimal. So in all my torics, be it an ICL or be it cataract toric, I have to do this under hydro insertion. Previously I used to use visco, but now I am totally on hydro insertion for toric.
Okay, so I think there are both options you can do. I mean, you are more comfortable doing it under hydro implantation.
Yes.
Can we have the Varion, please?
Check, yeah. So two things I'll show you now. One is its position with the Varion. It is still about 3 degrees short. I'll bring it in position at the last minute. और एक सेकंड जरा वेरियन हटा देना. And now I'll show you the lens and the central bump in it. Can you see that central bump?
Yes, the bump is visible.
Yeah.
If
So
you
this
make
is,
it retro, then it will be more visible. But
yeah. So this is 2.2 millimeter. It has a central elevated area of about a micron and a little change in curvature that extends the wavelength. And one is extends or stretches the wavelength, so it gives you that advantage of distance and intermediate. Okay, and I am bringing the final lens into position. It may be a good idea to stop the lens about 2 degrees short, and you have to press this lens against the posterior capsule before coming out, so that the chances of rotation of this lens in the early post-op period is minimal. दिखा दे एक बार last final check. So we are almost bang on. The inferior one is bang on. The superior one is probably a degree or two short, and this is the final position. Thank you.
thank
and
you,
we can
Sanjay.
move on to
Thank
the next
you.
surgery.
Thank you for a fantastic surgery.
Case, previous, previous. In the previous case,